Okay, welcome back to Unit 6 recording. So the next section we're going to talk about is altered thought processes. So we're going to start by some head injury. So a closed head injury, this is where an injury to the head in which the skull and dura mater remained intact. So there's nothing protruding, the head isn't cracked open or anything like that. It is simply contained within the skull. This can lead to problems with, this can lead to concussions, contusions, lacerations, hemorrhages, and then brain damage may be mild to severe. There can also be what's called the coup-counter-coup phenomenon. This is where bruising occurs at two locations on the brain. So you have one area which is the primary impact, so like somebody getting hit in the head with a bat, and then it causes the brain to bounce back and then hit the other side of the skull, as you can see in this picture here. So you have the coup, which is the first impact, and then the counter-coup, which is the secondary impact of the brain hitting the back of the skull as a result of the force. So whiplash, from a car accident. I have this little thing here, this note. I remember this girl in high school that she had smacked her head really hard on the basketball court during a high school basketball game, and she had a coup-counter-coup head injury from that, and it was pretty scary. She lost consciousness and then was definitely not oriented to person, place, or time when she became more alert, or more aware, I guess, awake looking. Okay, concussion. This is when damage occurs to gray matter of the cerebral cortex or brainstem. This is usually caused by some kind of violent shaking of the brain. Assessment, there's different assessments that you'll find, and it depends on how severe, the injury was. So they may experience an immediate loss of consciousness. This is very common to see during like football games. This is that player that is just laying there, for like a couple minutes, starts to come to, doesn't really remember what happened. That's our sign that maybe a concussion has happened. So drowsiness, confusion, memory loss of the event, or difficulty recalling some details. May have dizziness, loss of balance or coordination, headache, and blurred vision. Post-concussive syndrome. This I've seen quite a few times in the family practice setting where we have somebody that has had a concussion and then like weeks later or days later, it seems like it's coming back, and it may be even significantly worse than the initial injury. Can last for months and be episodic. They get those headaches. They get all of these again, sometimes even like weakness on one side, and they may get more confused and have a loss of balance. And we still have to do tests to rule out a stroke. Usually these people do have to get CTs and MRIs and that kind of thing, because we got to rule out a stroke because the symptoms are so similar. But typically they get the post-concussive syndrome. Diagnostics, a neuro exam by a physician may do a CT or MRI and possibly an X-ray. May be hospitalized or at home depending on their stability. These patients should never be left alone though. We want to promote rest as much as possible, avoid things that make the symptoms worse. So if exertion, watching TV, reading, or messing around on a smartphone makes your symptoms worse, then quit doing those things. That's kind of the general guideline. Medications, the primary medication is going to be acetaminophen. We want to avoid ibuprofen and other NSAIDs due to the risk of bleeding. And then myth. I always like to talk about this. Myth that used to be a thing, and you'll still hear it too. I'll be shocked if you haven't, that after somebody gets a concussion, they need to be awake for at least 24 hours. That is actually false. That sleep actually helps the brain heal. So this myth comes from a time before we had CTs to determine that, if there was a brain bleed or not. So, usually with some kind of severe head injury, they're going to get a CT or an MRI. And then if there's a brain bleed, then we know it's there. But if we don't see one there, then we can kind of say, oh, it's a concussion. This person needs rest. Prevention of concussion. So bike helmets that properly fit when playing contact sports like baseball or football, and then wearing a seatbelt in the car. Okay, the next head injury I'm going to talk about is a contusion. So a contusion is a bruise. Okay. The problem with this one is it's in the brain. All right. This is when small blood vessels under the skin break or tear. Assessment varies according to area and size of the injury. May have unconsciousness for a longer period of time. Faint pulse, hypotension, shallow respirations, pale and clammy skin, and then may have an altered motor response. Diagnostics here is going to be CT or MRI. Treatments depends on symptoms and severity of the case, but typically these people are going to have some hypoxia issues, okay, with those shallow respirations and hypotension problems, so apply oxygen. Consequences, they may form blood clots, may hemorrhage internally, and then have an increased intracranial pressure. All right, motor response. Usually what we're talking about is posturing, just so you guys know. So they may have a decorticate or decerebrate posturing. So when we talk about cerebral laceration, this is when now we have an actual tearing of the surface vessels in the brain or brain tissue. So this is bigger than those little itty bitty blood vessels from the contusion. This leads to secondary hemorrhage due to the bleeding and swelling in the brain. This is more serious than a contusion or a concussion. Assessment, deep coma from time of impact. Decerebrate posturing. This is where we have more of an extensor muscle reaction. And then pupils are non-reactive. And respiratory difficulties. All right, another thing I want to talk about is intracranial hemorrhage. So this is bleeding within the skull. This can happen in the epidural, subdural, or subarachnoid spaces, and even in the intracranial space as well. This is the most serious type of brain injury. This can lead to formation of a hematoma, which is a mass of blood. The neurological change is caused by an increased cranial pressure, may require surgical removal of blood clots. Watch for clients that are taking anticoagulants, NSAIDs, and aspirin, because they are at more risk for bleeds. If you've got that person that comes in that's on a, Coumadin or Eliquis or whatever it is, they're almost always going to get a CT of the brain if they have a fall, because we've got to check that out. So an epidural, and I've got it here, an epidural hematoma is between the skull and outer layer, which is called the dura mater. A subdural is between the outer and middle layer, and then the intracerebral forms within the brain itself. Of the three of these, typically the most severe is going to be your epidural hematoma. All right, this one is usually arterial in nature, meaning, those arteries have been lacerated or cut or are bleeding, whatever, and it fills up very, very fast, and then it starts squeezing the brain because of all that pressure. The subdural can be severe, but typically these are a slower leak and venous, they originate from a venous tear, so it's going to be a slower fill. Intracranial just depends on where it is and how bad it is. Typically, there is some kind of compensation the brain can do with the pressure, but again, where it's at and how bad it is might make it more severe than an epidural. But just so you know, epidurals can happen very, very quickly. All right, intracranial pressure. We talked about this earlier in the semester and last year as well. So cerebral spinal fluid is the fluid that runs between the brain's ventricles and into the spine. Its function is to cushion the brain and spinal cord. Normal level is 5 to 15 millimeters of mercury at rest. Any increase in volume of a component, meaning one of the ventricles or in the spinal cord, must be compensated for by a decrease in another component. Okay? So then one of the other ventricles has got to take on, that increase as well. Initially, homeostasis is maintained, but then those components will start to fail. Once the brain can no longer compensate, or the spinal cord, once compensation is no longer possible, that's when you start seeing that rise in intracranial pressure. So if you guys remember, assessment is Cushing's triad, which is increased systolic pressure, decreased heart rate, and decreased respiratory rate. Okay, I've got an assessment table here for increased ICP. There's early signs and late signs. You guys need to know this. Early signs, irritability, restlessness, personality changes. They can still have PERLA, may have some visual changes, weakness in one extremity, difficulty speaking. Vital signs might be slightly elevated from the stress. A late sign of increased ICP, decreased LOC, may have maybe in a coma state or have no response to pain. Pupils may be sluggish in the response to light or be dilated on one side. So they're not going to be bilaterally equal. They're going to be having one dilated. Vision can assess because of the decreased LOC. Motor function, decorticate or decerebrate posturing, like we saw in that picture from this slide over here. Speech can assess, again, decreased LOC, and then vital signs, we look for that Cushing's triad. So increased systolic pressure, decreased respiratory rate, and then decreased heart rate as well. May have Cheyne-Stokes breathing. Okay, other assessment, the Glasgow Coma Scale. This is an objective tool for assessing consciousness. It is scored at a 15, 15 meaning you're fully oriented. A 3 and less is deep coma. A 4 to 8 is a state of coma. And guys, key right here, a decreasing Glasgow Coma Scale finding is a reason to notify a physician stat. Okay, and then I got my other little thing here. Patient may be able to hear while in a coma. So don't talk to them like they are not there, and then you want to educate any visitors that they have that they may still be able to hear and process what you're hearing. I got this little note here to talk about a speaker that I had at my hooding ceremony. So a hooding ceremony, I don't know if I've explained this or not, but when you go to get your master's degree or your doctorate degree, doesn't matter where or what discipline. Mine was in nursing, but you guys know there's like education and like engineering and all kinds of different master's and doctorate level degrees. But anyway, when you get the big hood thing put over your shoulders with the colors and stuff over the graduation regalia, they call that a hooding ceremony. Anyway, the guest speaker at mine, she was a nurse, and she talked about when she was a nursing student that in her particular clinical, she took care of the same male patient for weeks. He was a young male in a coma. And she talked to him every day. She'd open his window. She'd tell him what the weather's like. She told him what she was doing with her friends. She told him about nursing school. She told him about her family. She did everything. And then weeks later, when she had moved on to another clinical experience, she was hunted down by the hospital staff because the guy woke up and he wanted to meet her because she had talked to him every day like he was there and he was listening, and he just really wanted to meet her. Like, oh my gosh, we were all crying at this this thing. It was so emotional. How amazing. Anyway, okay, so here's an example of a Glasgow Coma Scale tool. This one is either from a book or a different book, but they're all about the same. You might have a couple of variations to it. And then there's that total score. So best responsive 15. Totally unresponsive is 3 or less, or that deep coma. A comatose patient is 8 or less, like I talked about. All right, nursing interventions related to increased intracranial pressure changes. Raise head of bed to 30 degrees and administer oxygen. Monitor respiratory status. Remember with that Cushing's triad. Reposition every 2 hours. Tube feedings as ordered. Daily weights. Oral care every 2 hours. And perform passive range of motions if intracranial pressure is stable. All right, other treatments for increased intracranial pressure. Surgical, they may remove part of a bone flap to allow for brain expansion or remove a blood clot. A tube or shunt can be inserted. We talked about those, especially with the pediatric unit. Remember, those can be inserted to drain externally or into a different area of the body. And then medications. When there's ever any kind of head or spine injury, we're going to be looking at getting those steroids on as soon as possible. Corticosteroids, especially that dexamethasone. Antacids or H2 blockers, osmotic diuretics or loop diuretics, especially that osmotic or that mannitol that specifically pulls fluid from the brain. Antiemetics, because sometimes they do have GI issues with increased intracranial pressure. Antipyretics, because sometimes they will have problems with their brain being able to regulate their temperature. And then anticonvulsants due to the interrupted electrical currents in the brain. I've got my little cartoon here, warning signs after a head injury, looking for those changes in LOC. That's kind of the biggest thing. I can't tell you guys as a triage nurse how many phone calls I've had from parents that their kids have fallen. And usually the number one thing I ask is, how are they acting? You know, if they're screaming, crying that they're in pain, you know, that's pretty typical. You know, kind of give it a minute and see if they'll calm down. And if they're calming down, like, you know, are they still acting like normal? Do they still want to go play? You know, things like that. So that's what we talk about. Bleeding or drainage from nose or ears is going to be significant for damage that has happened. Any kind of drainage, like watery drainage, we can do the coffee filter test to see if it's cerebral spinal fluid. Remember that shows like rings. If you see the rings or the halo sign, that's positive for cerebral spinal fluid, or not positive, but it is probably cerebral spinal fluid. All right, I'm going to continue on to this slide in the next recording.